Welcome to Module 3, Using the CFCS to Inform Evaluation. After viewing this module, you will be able to explain why it is useful to use the CFCS to describe function when evaluating children's outcomes, describe how system-level data can support evidence-based decision-making, and consider how the CFCS may be used to support the evaluation of specific interventions. There are several reasons the CFCS is well suited for describing children's communicative function in outcome studies or in program evaluations. 3 are described here. First, the CFCS takes a positive and participation-focused approach to describing children's skills and abilities. It uses terminology that describes the level at which children are effective communicators, focuses on ability and participation, and is family-centered. Second, it provides a valid and reliable way to record information about children's function, both within and across impairment types. For example, not all children with developmental language disorder have the same functional abilities, and the CFCS provides a way for clinicians to describe those abilities reliably within this impairment type. The CFCS also provides a way for clinicians to describe function across impairment types. For example, to describe the communicative function of a child with speech sound disorder versus a child with developmental language disorder. Third, the CFCS is an empirically tested, reliable assessment tool. Using the CFCS, clinicians can share an empirically based common terminology rather than using terms like mild, moderate, and severe, which have not been shown to be reliable. As examples of how the CFCS can support our understanding of clinical outcome and evaluation data, examples from 2 population studies are presented. The first was an observational longitudinal study that used 2 tools to model growth in children's communicative participation skills. In this program evaluation project, data on children's communicative participation were collected using the FOCUS, or the Focus on the Outcomes of Communication Under 6, a valid, reliable, and responsive parent report outcome measure. Children's function was described using the CFCS, and a statistical method called mixed effects modeling was used to predict growth in communicative participation using data for almost 47,000 children. Looking only at predicted growth in focus scores with increasing age, the predicted average focus score for a child at 18 months of age was approximately 127, and scores were predicted to grow by about 5 points each month. By also incorporating CFCS classifications into the analysis, predicted growth in communicative participation was modeled in much greater detail and in fact shows that growth differed depending on a child's CFCS level. This table shows the coefficients from our statistical analyses. The first row shows predicted focus scores for children at 18 months of age. As you can see, the predicted score was highest for children in CFCS level 1, those who function best, and lowest for children in CFCS level 5, those who function least well. The second row shows the predicted rate of growth in communicative participation skills per month. This was similar for children in CFCS levels 1 to 3, between 4.3 and 4.7 points each month. Predicted growth was slower for children in CFCS level 4, just under 4 points each month, and for those in level 5, about 1.5 points each month. This slide provides a visual representation to show how predicted growth in focus scores differed for children in each of the 5 CFCS levels. The pink line represents predicted average growth, and the blue dashed lines represent individual variability around the average growth curve. This means growth in communicative participation depends on a child's level of function, and not all children should be expected to develop at the same rate. This is important and something that could be missed had the CFCS not been included as a descriptive tool in this study. In a second study, we used population data to identify predictors of growth in children's communicative participation skills. For some predictors, the original sample with almost 47,000 children was used, and for others that required data for children with multiple assessment points, a subsample of that group was used. Mixed effects modeling was used again to identify significant predictors of growth in children's communicative participation skills. But because of the large sample size, we only considered variables that demonstrated clinically meaningful differences to be significant predictors. On the original focus, a clinically meaningful change is 16 or more points, so this was our criterion for clinically meaningful predictors. Using this criterion, 4 variables were identified as significant predictors of growth in children's communicative participation. Participation in an early learning environment, whether children were receiving some form of active intervention, how much time children had spent in intervention, and intervention goals. Of those variables, intervention status is used to illustrate the benefit of incorporating CFCS classifications into system-level analyses. Using all available data, there was a significant main effect of intervention status on children's communicative participation skills. This means that children receiving some form of active intervention had higher predicted scores on the focus than those who were not receiving any treatment, and suggests a benefit to simply starting intervention regardless of a child's level of communicative function. By incorporating CFCS classification data in the analysis, we get a clearer picture of the impact of starting a form of active intervention. These 5 figures show predicted growth in communicative participation for children in each of the 5 CFCS levels, based on whether they were or were not in active intervention. The pink line represents predicted focus scores for children who were receiving intervention, and the blue line represents focus scores for children who were not receiving intervention. As you can see from the figures circled in purple, there were only clinically significant main effects for children in CFCS levels 2, 3, and 4, meaning that children in these levels experienced a significant increase in predicted focus scores when they started intervention, while children in CFCS levels 1 and 5 did not. Without incorporating CFCS classifications into the analyses, we may have wrongly concluded that all children experience a benefit from beginning intervention. It is important to note that these models show the impact of starting intervention, not outcomes over prolonged periods of time. Similar to the evaluation of system-level data, the CFCS can also be useful for understanding the outcomes of specific interventions. An example of practice-based research conducted at Western University illustrates how this might be done. The study explored communicative participation and impairment-based outcomes for children identified as late to talk, whose parents participated in Target Word, the Hannon program for parents of children who are late talkers. Parents of 24 toddlers participated in the study. Most children were male, and the average age was 20 months. All children were classified as CFCS Level 4 at the beginning of the study. One purpose of the study was to understand impairment and participation-based outcomes for children whose parents participated in the Target Word program. To do this, children's skills were evaluated using 4 valid and reliable clinical tools. Communicative function was described using the CFCS. Communicative participation was measured using the focus. Expressive vocabulary was measured using the MacArthur-Bates Communicative Development Inventories. And children's speech sound inventories were measured using an informal checklist developed by the Hannon Center. Data were collected at 4 time points. At the initial assessment appointment, parents completed the focus and speech-language pathologists classified children's communicative function using the CFCS. Prior to beginning the group training program, at the pre-program consultation, the focus and CFCS were completed again, and the MacArthur-Bates CDI and the informal speech sound checklist were also completed. Children's skills were reassessed and reclassified using those same tools at the end of the group intervention sessions and after a consolidation period, during which parents were instructed to continue working with their children at home, but had no direct contact with their speech-language pathologist. We were interested to learn how children's skills changed over the course of their time in the program, but also during the times in which they weren't receiving direct intervention, like the times between initial assessment and pre-program consultation appointments, and between the end of direct treatment and the end of the consolidation period. This slide shows growth in children's communicative participation, or focus scores, over the course of the study. The blue bars represent the average total focus score at each assessment point. We found statistically significant change on the focus between initial assessment and pre-program consultation appointment, and also during the time in which children were in direct intervention. Growth in focus scores during the consolidation period was not statistically significant. We also found that change on the focus was clinically meaningful, or more than 16 points on the focus, between the initial assessment and pre-program consultation appointment, and during the period of direct intervention, but not during the consolidation period. Because children made statistically and clinically meaningful change during the face-to-face part of the program, but also during the time between initial assessment and start of the program, we could not definitively conclude that the intervention was responsible for the change. This slide shows growth in expressive vocabulary measured using the MacArthur-Bates CDI. We found statistically significant growth between the start and end of direct intervention, and also during the consolidation period. Because children made significant gains during both periods, we could not conclusively attribute change to the program, but this may have been possible had we been able to compare data from a waitlist control group. This slide shows growth in children's speech-sound inventories as measured using the informal checklist developed by the Hannon Center. We found statistically significant growth in speech-sound inventory during the direct intervention period, but growth was not significant during the consolidation period. We could not attribute these changes directly to the program because we were unable to collect this data at the initial assessment appointment, and because by the end of treatment, children's consonant inventories were within the range of age expectations, so additional growth was not necessarily expected. This slide shows children's CFCS classifications over the course of the study. All children were classified as CFCS Level 4 at the initial assessment appointment. That is, they were all inconsistent senders and/or receivers with unfamiliar and familiar partners. During the time between the initial assessment and the start of direct treatment, classifications remained the same. But by the end of the direct intervention period, 10 children were classified as CFCS Level 3, they were consistent senders and receivers with familiar partners, and 2 were classified as CFCS Level 2. They were consistent but slower-paced communicators with familiar and unfamiliar partners. This was a significant proportion of children. The way in which children's skills were classified was different again at the end of the consolidation period, when only 5 children were classified as CFCS Level 4, 13 were classified as CFCS Level 3, and 6 were classified as CFCS Level 2. Children's classifications stayed the same between the initial assessment and the start of direct intervention, but they were classified as being more effective senders and receivers at the end of the direct intervention period and then again during the consolidation period. To summarize, during the Target Word program, children who were late to talk improved in their communicative participation skills, expressive vocabulary, consonant inventory, and were described differently in terms of their communicative function, providing some evidence for effectiveness of the program. Only changes in the way communicative function was classified could be directly attributed to the program. In summary, the CFCS is useful because it provides a valid, reliable, and positive approach to describing children's communicative function. At a system level, outcomes can be better explained and understood when children's abilities are described using the CFCS. This type of detailed information may be useful for those wanting to make evidence-informed decisions about service delivery and policy. The CFCS also provides an additional tool that can be used to describe how children develop over the course of individual interventions.